Hello and welcome to iTenf Healthcare Solutions webinar. This one's on patient-centered medical homes, all the questions you've asked answered. My name is Chelsea Grover and I'm the Marketing Communications Coordinator for iTenf. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. We'll send out a copy of the slides along with the recording within the next week. Next, for those of you who aren't familiar with iTenf, I wanted to share a bit of who we are with you. We specialize specifically in NextGen healthcare. We're passionate about providing solutions for healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. To sum it up, we do everything NextGen. And we also have two add-on productivity solutions for NextGen, ChartGuard and Refund Manager. Next, this is usually when I would mention upcoming webinars, except at the moment we haven't selected a topic for the webinar yet, so if there's a specific subject that interests you, please let us know. We always love feedback and topics on what you want to learn about, so please either use the chat box to let us know or shoot us an email. Okay, so back to today's webinar on PCMH, all the questions you've asked answered. At the end of the presentation, we'll open the floor up to questions from you. We'll answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today. Cindy Kincaid is Vice President of Client Solutions, Lindsay Lanning is our Healthcare Compliance Consultant at iTenf, and Mary Hart, Solutions Manager at iTenf, will be available to help with questions at the end. So Lindsay, the webinar is all yours. Feel free to get started when you're ready.
Great, thank you, Chelsea. Well, hi everyone, and thank you for joining us today for our webinar, PCMH, all the questions you've asked answered. We have been hearing from a lot of clients. They are either currently part of a PCMH or are considering becoming one in the future, but just don't feel like they have all the information they need. As a result, we took the time to sit down and, based on your feedback, address questions and concerns that have been brought to our attention by all of you. Our goal is to make understanding the 2017 PCMH standards, the new NextGen PCMH reporting suite, and the benefits to becoming a PCMH easy for you. We realize there's a ton of information out there and it's constantly changing, and we want to help you decipher what's important and what you need to know when it comes to considering PCMH recognition in 2018, but also beyond. Specifically on today's agenda, we're covering the topics, again, brought forward by all of you, our clients and our webinar attendees. First off, just a general PCMH overview. What is it and why consider it? Really getting a sense of what this model is all about. Next, we will look in depth at the 2017 NCQA PCMH criteria and the recognition process. This is beneficial even if you already are a PCMH or becoming one, since at the structure of the program and reviewing the requirements of this new set of criteria that replaced the 2014 standards. And lastly, we'll look at NextGen and the PCMH model, focusing on things like auto credit and the documentation you need, and also the ability to access it with the success community, as well as the new PCMH reporting suite. So let's get started with some background information here first. First off, what is it? Well, the patient-centered medical home is a care delivery model whereby patient treatment is coordinated through their primary care physician to ensure patients receive the necessary care when and where they need it in a manner that they can understand. So the objective is to have essentially a centralized setting that facilitates partnerships between individual patients and their personal physicians. This really emphasizes care coordination and communication to transform care based on a patient's preferences and needs. The PCMH recognition is voluntary for medical practices, and this model specifically is focused on the Quadruple Aim, previously known as the Triple Aim, which involves improving population health, improving the experience of care for both the patient and provider, and reducing the cost of care through greater efficiencies and improved care coordination. If we look deeper into what the Quadruple Aim tries to accomplish, we can begin to understand how this model can transform our practice with this widely accepted industry initiative at its core. So in 2007, the Triple Aim initiative was launched, and it focused on improving population health, so patients getting the treatment they need when they need it. Then improving the patient experience, focusing on quality, access, and reliability, but specifically the personalized, comprehensive, coordinated care that patients want. And then reducing the cost of healthcare by preventing expensive and avoidable hospitalizations, as well as emergency room visits, and complications. This is especially true for patients with complex chronic conditions. Now, just recently, due to many factors such as physician burnout and physician shortages we've been hearing a lot about lately, the Triple Aim has been expanded to the Quadruple Aim. And that was done to include a physician-focused aspect of improving the work life of healthcare providers, including clinicians and staff. This slight shift in mindset by the healthcare industry to not only focusing on the patient experience, but also the provider experience is fully supported by the PCMH model and encourages practices to perform more efficiently. Now, as we know and we're well aware, healthcare in the United States is moving away from volume-based payment and toward a value-based system. PCMH transformation will allow your practice to have a better position to respond to this change, and it's shown not only through its alignment with important industry initiatives like the Quadruple Aim, but also through its support by organizations such as big names like CMS, MGMA. You have the American College of Physicians or the American Academy of Family Physicians. We also have state agencies. States continue to use the medical home model to promote primary care through various public sector programs. And actually, just kind of a fun fact here, as of March 2017, I didn't realize how high the numbers were. More than 20 public health sectors initiatives require or recognize PCMH recognition. The HRSRA, government contracts that promote the PCMH model in FQHCs exist. Current contracts with the HRSA actually provide financial support for the cost of PCMH recognition and technical assistance in achieving recognition. The American Academy of Pediatrics actually offer clinicians in recognized practices to be able to receive maintenance of certification credits towards their board level certification. So you can see the image in the upper corner. Any organization with that hospital symbol also offers this. And there are many more. This is just a screenshot of the very first page of this resource. And then lastly, payers. Many payers, government and private, offer incentives or enhanced reimbursement for becoming a recognized PCMH. Again, you can see on that image, any organization showing a dollar sign offers some sort of financial assistance or incentive, which it makes a lot of sense. As payers look to reward value, they are increasingly supporting PCMH because that model can help patients avoid costly complications. One specific organization I mentioned on the last slide was CMS. And if you know me or you've been on any of our previous webinars, you know I couldn't miss out on an opportunity to talk about my favorite piece of legislation, which is MACRA. MACRA, we know, created the Quality Payment Program, and that's the incentive program under Medicare for providers to participate in. And they can do that in one of two ways, either under MIPS or as an APM. The majority of clinicians report under MIPS, and within MIPS, there's 4 performance categories: quality, cost, promoting interoperability, which was formerly the ACI category, formerly meaningful use. They like to change the name a lot. And then improvement activities. And I highlighted improvement activities for a reason. And that's because clinicians in recognized PCMHs or PCSPs receive automatic full credit in the MIPS improvement activities category. Therefore, becoming a PCMH is going to directly increase your clinician payments through the merit-based incentive payment system. I will go ahead and take the opportunity to mention for 2018, there have been a few changes, especially if you're already considered a PCMH on this call, just comparing it to last year in regards to how you can qualify as a PCMH under the Quality Payment Program. This information is included in that blue box on the side. The main change being that 50% of practice sites within a TIN must be recognized as a PCMH to get full credit. Previously, you only needed to have one site. But, all right, I will go ahead and I will step down from my MACRA soapbox. I just couldn't pass up my chance to include this little piece of information, not only because I love working with it, but also because it exemplifies how integrated this medical home model is with the industry. You've seen how it supports fundamental industry initiatives like the Quadruple Aim, incentive programs like MIPS, and all the organizations and societies that are helping shape the healthcare arena. This model really aligns with everything we talk about when it comes to the future of healthcare and value-based care. But enough background and legislation. Let's get into the actual recognition process, starting with the qualified accrediting bodies. And they include the National Committee for Quality Assurance, or NCQA, Accreditation Association for Ambulatory Healthcare, the Joint Commission, and the Utilization Review Accreditation Commission, or URAC. Now, I will say a number of local, state, and national PCMH recognition and accreditation programs exist. However, the 4 I listed are going to be the largest, most widely accepted, and recognized programs in the healthcare industry today. The accrediting body we will be focusing on today is the first one I mentioned, NCQA. NCQA really does offer the most widely used PCMH recognition program for providers, and it uses standards which were redesigned in 2017. The NCQA PCMH recognition process requires healthcare organizations to carry out basically these practice transformation activities that are aligned with a set of concepts, competencies, and criteria. So this recognition program, like I said, truly is the most widely adopted PCMH evaluation program in the country, with more than 12,000 practices, including over 60,000 clinicians being recognized by NCQA, and more than 100 payers supporting NCQA recognition through financial incentives or coaching. This is in part because NCQA released its program the year after the PCMH model was even introduced, making it the first evaluation program in the country. So it makes sense. Now, the current program, like I said, is PCMH 2017. The 2014 program ended on October 1st of last year. This redesigned program includes ongoing sustained recognition status with annual reporting, instead of a 3-year recognition cycle which existed previously. NCQA really based the redesign on feedback from practices like you, policymakers, payers, and even other stakeholders. They also considered the changing payment climate when it came to the new standards. Recent changes in federal law, cough, cough, MACRA, changed payments to reward value-based care. And their redesigned process aims to align reporting requirements with MACRA to eliminate duplication of work. The new program also improves focus and flexibility while reducing the total criteria to 100 from previously 167 in 2014. There's also a new core and elective approach, which allows practices to tailor the program to their population. So, in my opinion, the program's much more manageable by reducing paperwork and really increasing your interaction with NCQA while continuing to concentrate on performance and quality improvement. The idea here really was to support continuous practice transformation that accommodates a spectrum of practices, so from basic to complex practices and from small to large practices. Now, if you are familiar with the 2014 program and not the new 2017 one, NCQA has developed crosswalks comparing the past PCMH standards to the new PCMH criteria. This table compares the NCQA 2014 standards with the 2017 standards. You can see the columns here show where meeting 2014 factors also meet 2017 criteria and where there are differences. So you'll see where it says no equivalent, if there's a check mark, it works out, or if there's any other notes in that alignment section, that'll give you the details you need to move forward. Now, before I move on completely to the recognition process and implementation strategies, I did want to mention the other recognition program that is a bit newer, but very similar to the PCMH model, and it's still sponsored by NCQA. And this is the PCSP, or the Patient-Centered Specialty Practice Designation. So the PCSP is basically NCQA's designation for specialty medical homes. It requires commitment to access, communication, and coordination. A practice must demonstrate patient-centered care and clinical quality through streamlined referral processes, care coordination with referring, timely patient and caregiver-focused care management, and continuous clinical quality improvement. So you're going to hear me mention this model a lot as well throughout the presentation. It does have the same focus as a PCMH, just for specialty practices. All right, moving on to implementation strategies and how to get your staff, your clinicians, and your patients on board for this practice transformation. I'll go ahead and hand it off to Cindy, our project management expert, to highlight some key points that will come in handy when addressing each of those populations. So Cindy, it is all yours.
All right, thank you, Lindsay. Okay, in order to begin an implementation, everyone involved has to understand what the benefits are. So as we move to the clinician benefits, we'll talk about how you can earn higher reimbursements. More than 100 payers nationwide offer either enhanced reimbursements for recognized clinicians or support for practices to become recognized. It can help you succeed in MACRA. As Lindsay mentioned, one of her favorite subjects, not mine, by the way, this is an area that can actually help you move forward with that. The Centers for Medicare and Medicaid Services acknowledge both NCQA's PCMH and PCSP recognition programs as ways to receive your MACRA credits. Clinicians in NCQA recognized PCMHs and PCSPs automatically earn full credit in the MIPS improvement activities category. That means they're likely to do well in other MIPS categories. The PCSP recognition program is the only specialty-focused evaluation program in the country recognized by CMS and MACRA. You can earn maintenance of certification MOC credits. Several medical boards award clinicians NCQA recognized practice maintenance of certification MOC credits. This is reducing the burden on clinicians to take on additional activities. So you need to find out whether your board offers credits or not. And finally, and I think one of the most important things, it allows you to focus on patient care. While we're talking about all of the programs and all of the increased reimbursements, the bottom line is it's patient care. The PCMH model ensures that team members operate at the highest level of their knowledge, skills, abilities, and license within their assigned roles and responsibilities. Then we move on to the benefits to the patients. And the patients themselves, what this allows you to do, because population health management lies at the core of the PCMH model, it requires the practices to regard patients as individuals and as members of a population. Doing so allows the practice to identify the pressing and pending health needs of its patient population and determine how best to prevent or meet those needs. When medical home attributes are described to people, they say it's the type of care they want to receive. It offers the patient a better experience because it's very well-rounded. It also ensures that the patients who can will stay healthier. Patients who are treated in PCMHs tend to receive preventative services and screenings at a higher rate than patients who are not in a similar program, thus helping them stay healthy. Full cooperation in the program allows better communication. Communication with patients and their families and caregivers is a core concept of the PCMH model. It also emphasizes enhanced patient access to clinical advice and medical needs and medical records. And finally, better management of chronic conditions. According to research, PCMHs are especially helpful for patients with complex chronic conditions because you're reaching out to them, you're working on helping them maintain their treatment plans and stay on point and allowing them to at least remain as healthy as they can with those chronic conditions. And then we move on to the benefits to the practice as a whole. Keeps your staff happy. The PCMH model helps streamline processes and standardize procedures that keep practice staff at the top of their knowledge, skills, and ability. It has been shown to result in higher staff satisfaction. It allows you to improve your practice overall. Use the NCQA PCMH recognition to perform a gap analysis and to implement processes and procedures that improve care for patients and make your practice more efficient. It also allows you to support revenue growth in this ever-changing model of healthcare. Many federal, state, and commercial payers offer incentive programs to practices that achieve the NCQA, PCMH, or PCSP recognition. And toward that aim, it aligns where healthcare is headed. Payers continue to move from a fee-for-service model towards rewarding integration and quality care. They are increasingly contracting with organizations that can show they have a strong infrastructure and quality improvement initiatives in place. NCQA PCMH recognition prepares you to succeed with those type of changes. And then finally, it allows you to market your practice. The NCQA publishes a list of all recognized practices and clinicians in its recognition directory. Use the NCQA seal to market your accomplishment to your patients and partners. We can even help you distribute a press release to local press touting your achievement. It is really important, again, in this ever-changing climate of healthcare that your patients, it's now a competitive, and your patients need to feel like they're on the leading edge and that they're getting the benefits they want, because there are always others out there that are willing to do that. Then we move on to the cost benefits. The cost benefits. Studies have shown that reduction in per capita expenditures exceed investment by commercial insurance and Medicaid. It allows for increased utilization of non-medical support services and decreased use of specialists, decreased costs through elimination of duplicative services due to better care coordination, and it offers a prevention of expensive and avoidable hospitalizations, emergency room visits, and complications. In short, being on top of it and getting ahead of the situation allows the cost benefits that will move you towards a more efficient practice. So to move forward, we've talked about all of the benefits. Make sure everyone understands that the benefits are there, but now the most important thing is to gain staff buy-in. So the way you would start is change is hard in general, but it can be particularly difficult to manage across teams in a medical practice. Everyone is involved in a PCMH. Meeting standard requirements and continuously maintaining and enhancing your ability to improve while continuing to focus on patient-centered care and outcomes is challenging. Not only must those processes and procedures change, but the very culture of your practice may have to shift as well. And practices must be able to live with the changes every day. So how do you implement team buy-in? Moving to team-based care means putting patients at the center of what you do. That requires your team to function as a unit. The walls of process and communication silos must come down. So here's a few suggestions for beginning the buy-in process. First of all, you want to designate a team champion or two. Train leaders well and give them the backup and support they need to deploy this throughout your practice. Once you've developed your policies, put them in writing. Align job descriptions and a performance metric so that everyone understands. Then you want to maximize your efficiencies. Ensure that each team member is practicing at the top of their license or skill set, and make sure they have the education they need to move forward with this new area that you're embarking on. And include your team's input and involve them in the improvement activities. That's going to be critical, because what you want is if everyone that's involved, they're going to feel like they're a part of the process, and that will make them also want to make it succeed and help you with it succeed. So after you've done this and you're ready to move on, you're ready for the next stage, and you want to talk about the recognition program structure, and I'm going to turn it back over to Lindsay for that.
Great, thank you, Cindy. All those points you mentioned, I think, play an integral role in gaining the support you need prior to beginning the recognition process. It really is extremely important. So let's go ahead and look at the NCQA PCMH recognition program structure to understand if your practice is eligible to become one and what you need to do to actually earn recognition, or if you already have it, maintain it. So in very broad terms here, NCQA has broken down the recognition process into 3 parts: commit, transform, and succeed. During that first commit phase, you're gaining physician, staff, and patient buy-in using the strategies we talked about previously, highlighting those key points Cindy went over. This is the time when the practice learns those concepts and begins to apply them with their practice. And that takes you to the transform phase, when you're actually participating in certain activities and you begin to collect evidence to support those activities. And then lastly, succeed. This will be once you've actually earned your recognition and then partake in annual reporting each year to maintain it. And that really is what the entire process, from a very high level overview, looks like. We're going to go ahead and break that down and provide much more detail on each phase, so just wanted to show you where we were going. So if you are asking yourself, this all sounds great, but where do I even begin? What do you want me to do first? And the first place I would start is with eligibility. Clinicians who are eligible are those that hold a current unrestricted license as an MD, a DO, an advanced practice registered nurse, or a physician assistant. Only clinicians who can be selected by a patient or their family as a personal clinician are actually eligible to be listed on the NCQA's website under your practice recognition. The practice can actually define a personal clinician as a residency group under a supervising clinician or a faculty physician, or a combination of physician and advanced practice registered nurse or PA who share a panel of patients. Now, an eligible practice consists of one or more clinicians who practice together and provide primary patient care at a single geographic location. And when I say practicing together, that means all the clinicians in the practice follow the same procedures and protocol and have access to and share medical records for all the patients treated at the practice site. So to be specific, this can include nurse-led practices in certain states. However, it doesn't include sites like urgent care clinics or any clinics that are only open on a seasonal basis. We're really focusing on primary care. Now, it's important to note that recognition is achieved at the site level. There's one recognition per address. And any MDs, DOs, PAs, and APRNs are listed on the application, since all eligible clinicians at a site must apply together. Clinicians should be listed at each site where they routinely see a panel of their patients, and any non-primary care clinicians should not be included. So that means at least to be a primary care physician, at least 75% of each clinician's patients should come for a first contact of care, would select them as their personal PCP, and provides continuous care and any comprehensive primary care services. There is a multi-site eligibility available, but you must answer yes to all three of the following questions. So can your organization sign one PCMH program agreement to cover all sites applying for recognition? Do all the practice sites applying for recognition share and use in the same way a practice management system or EHR to document patient care for administration and billing? And do all the practice sites applying for recognition operate under at least some of the same policies and procedures? If you can answer yes to all of those, you are eligible for multi-site recognition. So once you determine if you're eligible or not to become a PCMH, the next step is actually understanding how recognition works and what your practice needs to do to meet the requirements. So let's look at the structure of the program and how it's set up. Today, the PCMH program has evolved to feature a set of 6 concepts that make up a medical home. So underlying these concepts are criteria, or the activities for which a practice must demonstrate. So you have these concepts, there are 6 of them, and they're really just the overarching themes of PCMH. To earn recognition, your practice must complete criteria in each concept area. If you're familiar with the past iterations of NCQA PCMH recognition, these concepts are equivalent to what the standards were. Next is competencies. Competencies basically just categorize the criteria. They don't offer any credit. It's just a way to think about or group the criteria. And then lastly is the criteria, and these are the specific activities in which a practice engages to demonstrate that it meets recognition requirements. So these are the individual tasks or the things you do to make you a PCMH, and these will actually transform your practice. So the 6 concept areas under PCMH are team-based care and practice organization. This is really focused on helping structure practices leadership, their care team responsibilities, how the practice partners with their patients, even their families and caregivers. Next, we have know and manage patients. This basically sets standards for data collection, things like medication reconciliation or any clinical decision support tools. Patient-centered access and continuity. This basically guides a practice to provide patients with convenient access to clinical advice and helps ensure continuity of care. Next, we have care management and support. This helps clinicians set up care management protocols to identify patients who need more closely managed care, so making sure none of those patients fall through the gap. Care coordination and care transitions. It ensures that primary and specialty care clinicians are effectively sharing information and managing patient referrals to minimize cost, confusion, and make sure there's no inappropriate care being given. And then lastly, performance measurement and quality improvement, which helps practices develop ways to measure performance so they can set goals and develop activities that will lead to improvement. So you'll see for every criteria a breakdown like the one above. You have the concept, which uses a 2-letter abbreviation when identifying it, so don't be surprised when you see that. So for team-based care, that concept is abbreviated as TC. Then the competency, which is just, again, that criteria subgroup. And then the actual criteria, which states the PCMH requirements. So it can sound confusing when you're just trying to talk it out, but I think this visual helps break it down and make it more meaningful to see how this structure actually works. So to receive recognition, practices must complete all 40 core criteria and earn 25 elective credits. Elective credits are a mix of 1 to 2 credits, and they have to cover 5 out of the 6 concepts we just went over. Each criterion in the standards is noted with its assigned value concepts, and you can see the image on the right is showing how many credits are available under each concept and competency. I do want to note too, NCQA does offer special acknowledgement for distinction in behavioral health integration, reporting of electronic quality measures, and patient experience reporting, so gathering feedback using HEDIS or CAP surveys. I do want to call out one of those special distinctions because I think a lot of you on this call would qualify for this and may not know it, and that's the eCQM acknowledgement. Practices have the option to submit CQMs to NCQA in support of the recognition process. So measures can be submitted using electronic health records, QCDR, which are clinical data registries, and any other data analytics company, as long as they use the CMS electronic specifications. NCQA actually has a list of 35 CQMs that are relevant for primary care practices. They would just have to submit them using that QRDA format, which is standard industry-wide. And then distinction would be awarded for 1 year to PCMH practice sites that submit at least 6 measures for each clinician. Now, I hate to do this again, but does this ring any bells with anyone? The submission methods of EHR or registry, or maybe the number of measures required being 6? I am sure I'm getting some heads nodding yes out there, and it should sound familiar since this is perfectly aligning with the quality category requirements under MIPS reporting. So I say again, the same CQMs that are used for the CMS Quality Payment Program can also be submitted for recognition under the NCQA PCMH Recognition Program. You are truly killing 2 birds with 1 stone, and to make it even easier, NCQA provided a crosswalk to identify CQMs that overlap with MIPS, HEDIS reporting, PCMH, and even CPC+. I did include all 3 pages for your reference since as we get closer to the end of the year and you begin selecting your quality measures, you may want to see if these are feasible for you, and you could be well on your way to PCMH recognition. But make sure, again, you choose relevant measures. You want to know the measures you choose are important or at least worthwhile to your practice as a whole. All right, so back on track here after another minor MACRA interruption with the criteria and what needs to be met. So again, you have the 40 core criteria and then the 60 elective where you have to get 25 credits. Again, here's just another graphic to better understand how the elective scoring works. So in this image, each row represents a concept which is laid out with the number of electives included, and then the credits are identified in the middle of each circle. The blue circles are actually showing you an example of electives chosen by a practice to equal 25 credits. And then the red circles are the electives left over that the practice are not going to report on. So just another way to make this concept even more clear and support it with some kind of visual representation here, just depending on how you'll better understand it. Now, you may be wondering, okay, how do we meet this criteria, or how does NCQA know we met it? And that's where evidence comes into play. Practices must submit evidence demonstrating performance against specific criteria. They're encouraged to implement and document process-based evidence early on in the process. And generally, any reported data should be no more than 12 months old. So go ahead and think of an audit, a meaningful use audit, if you will. You have to back up and prove you're doing something in order for them to accept it. And this is the same concept. You need to prove you're actually meeting the criteria you selected somehow. There are two types of evidence, documented processes and evidence of implementation. The documented processes are written statements describing the practice's policies and procedures. They include things like protocols, any practice guidelines you have or agreements you have in place, other documents describing actual processes or forms. So think of referral forms, any checklists you have or flow sheets. And then you have evidence of implementation. This is basically a means of demonstrating systematic uptake and effective demonstration of required practices. It includes reports, screenshots, any attestations. So maybe you have your Medicaid meaningful use attestation on file, patient records or specific examples, your eCQMS, any survey data from HEDIS or CAPS, and data entered in QPath, which is the NCQA system as well. This also includes NextGen auto credit or any vendor auto credit. We'll touch on this a little bit later on. Now, if we put it all together, we have the concept at the top, then the competency, the criteria with the specific activities, and then the evidence required to support that criteria being met. And you will see actually the two types listed on the screenshot. And then you have guidance from NCQA as well. And guidance includes things like information on the intent of the criteria, certain expectations NCQA may have, how this criteria relates to other criteria, any terminology used, or even aspects of the evaluation process. But that's it. That's how you determine what's required of your practice to become a PCMH. It's the transformation of your practice to meet those requirements and provide evidence to support your activities that will earn you that recognition. Now, it really is just the actual process, the technicalities behind it of how to gain the recognition of where to go and what you actually have to submit once you meet those core and elective criteria that's left for us to look at. So first off, if we look at the recognition basics here, I'd say you need to determine if you're eligible or not. I think that's pretty obvious. Once you determine if you are, it's recommended that you perform a gap analysis of your practice and identify where you might need to transform. Once your practice really is knowledgeable of the concepts and you've begun actually transforming into PCMH, you're going to enroll in the NCQA QPath system, and you're going to complete an initial questionnaire. So you're going to use this Quality Performance Assessment Support System, which is what QPath stands for, to gather evidence, prepare documentation, and even track your practice's progress toward recognition. Once you are enrolled, NCQA actually assigns you and your practice a representative, and they're going to be your single point of contact to guide you through the process. Your rep will go ahead and schedule an initial call. You'll introduce yourselves, they'll introduce themselves to you, you'll discuss the process, and even develop a review schedule. And that review schedule will include 3 check-ins. These check-ins or virtual reviews will give you immediate and personalized feedback on what's going well and what needs to improve. So during these check-ins, you're going to want to address any transfer or shared credit with your rep. So any transfer credit is from pre-validated vendors. So if you choose a vendor with existing auto credit, The vendor supplies a letter of implementation confirming that, and then criteria on your QPAS portal will automatically be set to met after confirmation. NextGen is one of these vendors, and we'll cover that in the last section for you, so that's exciting. And then shared credit. Shared credit is for organizations with multiple sites, and it basically allows practices to share any evidence or credit for any criteria they've completed across the board. Now, once you've completed your check-ins and earned your recognition, each year after, the practice checks in with NCQA to show its ongoing activities are consistent with the model of care. This is basically part of the annual reporting process. You may have to attest to some policies and procedures. They may require you to submit some data. This process basically is just sustaining the practice recognition and making sure that you're continuously improving. So if you are concerned about shared credit, when I mention that, you want to make sure you identify shared credit from a shareable list in QPAS. So this is, again, if you're a multi-site eligibility, and that you want to identify one site as the primary site. Since this is the only site that will receive a full review, and then any shared credit will auto-populate in the subsequent sites. Now, the review process definitely, I would say, is the last and most critical step. I mentioned that there would be 3 check-ins or virtual reviews. Basically, during these, you want to predetermine your criteria to address. You want to focus on any core and documented processes first, and then identify criteria for your 25 elective credits. Make sure you provide documents for off-site review, which include things like your policies, your procedures and protocols, links to maybe your website, or maybe even your attestations. But you also want to provide evidence during the virtual review. So make sure you're communicating with your evaluator. Substitute evidence if something's not sufficient. Demo your systems to them, and also provide reports, but have these done before your review, and make sure to remove any and all PHI from documents beforehand. After check-ins, the evaluator marks that the criteria was either met or not met. If it was not met, the practice can work on that before their next review. And then the NCQA staff will also review any questions arriving from those check-ins and get back to you. Now, after all 3 check-ins, the practice should meet all core criteria and 25 elective credits. The results are forwarded to the review oversight committee. If for some reason the required criteria is not met, an additional check-in is available for purchase, so they do have this stuff available for you if it's just not moving along as fast as you'd like. The same thing, if the process isn't completed within 12 months, you can have additional time purchased. Now, after you're recognized, it doesn't stop there. I mentioned you have to participate in annual reporting. You're going to want to complete your annual reporting 30 days before your recognition anniversary date. That date's just 1 year from your recognition date. You will be asked to attest that you're performing activities that make up the PCMH requirements. You may be asked to demonstrate that you're embracing measurement and quality improvement, so maybe providing some documentation or measurement data. I do want to note, though, you can actually provide evidence at any point within the year, but it's only going to be reviewed after the reporting date is passed. So you can gradually upload this to the QPAS system instead of all at once. But from what I've heard from clients, annual reporting requirements are flexible to meet your practice's unique needs. You're probably performing most of the required tasks already. And NCQA has stated any new requirements they may introduce are announced 1 year ahead, and the practice must meet them by the next reporting date. All right, it looks like we've made it to our last section here. But before I move on, I will say, all in all, once broken down and understood, the process of transforming into a PCMH becomes quite manageable, especially due to the overlap of quality initiatives you're most likely already reporting on. Now, if you are a NextGen client on this call, you have even more of an advantage when it comes to PCMH recognition, and I'll go ahead and turn it over to Cindy to take us home and discuss how NextGen supports PCMH recognition for clients, since there are a number of ways. So Cindy, it is all yours.
All right, thanks. So we're going to bring this in now. So we're going to talk now about the pre-validation program that NCQA offers. They offer a pre-validation for EHR vendors that will assist clients in achieving points towards accreditation. NCQA pre-validated health IT solutions have successfully demonstrated that their technology function has the technical functionality that supports or meets one or more criteria in the PCMH standards. NCQA pre-validated evaluation can result in approved fully met criteria or partially met criteria that allows transferable to eligible clinic practices, submitting for recognition and acknowledgement of the practice support functionality. I would not even want to try to say that again. Basically what they're saying is that by doing this and having a system that has been certified or pre-validated, you now are part of the way home in getting your accreditation. A health IT solution must demonstrate it fully meets all required functionality and provides all required evidence specified by the criteria to receive this designation. Practices are fully excused from criteria met with full credit by a vendor solution and do not have to do any documentation for these requirements. I'm sorry, all these acronyms are starting to get to me a little bit. So a health IT solution will allow you to then obtain auto credit. So practices may apply these auto credits as evidence of implementation for applicable PCMH criteria. The practices must be using pre-validated EHR technology, including corresponding features and workflow. So it's really important to note that NextGen Healthcare has pre-validation for the 2017 NCQA, PCMH, and PCSP programs. As we take a look at this validation, here's an example of the letter that has been submitted. And this is a letter that you will be needing when you're submitting for these, but won't go into reading the letter to you, but you can take a look at this. And then it has a pre-validation overview for client practices. NextGen has received auto credit for 23 factors, which will allow a total of 17.87 points right out of the gate. And here's an example of the NextGen PCSP pre-validation. Again, they have also been pre-validated as a specialty, and you can see this 2016 summary approval tables, which we've talked about before. So what this basically means is it's using NextGen will receive 17 points in awarded auto credits, and practices claim this credit in the NCQA QPass portal, and we'll talk a little bit more about that as we move forward. So how do you use the credits from NextGen? First and foremost, step one, obtain a letter of project implementation from your vendor, indicating pre-validated tools and the modules approved for transfer credit have been implemented at the practice. Along with the implementation letter, you may or should receive the vendor's pre-validation letter of credit approval. Step two, you're going to log into QPass and complete the following steps. You'll click My Evaluations, hover the cursor over Action, and click Organization Dashboard. Click the Transfer Credits button, select the program screen, click Vendor, click the applicable practice sites. Using the Evidence component, upload the letter of product implementation, click the Submit button for review, and then the final and third step is receive approval from your NCQA representative. Once your transfer credit is approved, all eligible criteria with the transfer credits will then now be marked as met. How do I get this PCMH or PCSP pre-validation letter? Much like you've done with many of the other things through meaningful use or other areas when you've had to validate, you're going to open a support case using the category Health Quality Measures, HQM, and the topic PCMH or PCSP pre-validation letter request. It's really that simple. Include the following in your description of the case. Reason for the request. Which one are you trying to accomplish? Indicate which of the following solutions your organization is using. NextGen HQM, NextGen Patient Portal, the date to submit the PCMH survey, the name of the organization if it's different from your master agreement, the address of the practice to address the letter to, the client contact name and email. Provide it in your upgrade history by running a SQL script. Attach a screenshot or CSV file to the case. If you're hosted by NextGen or Itentiv, they will run the SQL script for you. I'm guessing if you're hosted by another vendor, they will likely do the same. So as we talk about the NextGen Practice Support designation, NextGen has also received practice support credit on all MU-related 2014 CEHRT and other factors totaling 23 factors. When a health IT solution demonstrates aligned functionality that significantly supports a practice in meeting the NCQA criteria level requirements, it receives a practice support designation for these criteria. So for example, a health IT solution provides prepackaged reports designed to meet the needs of a PCMH practice. In order to accomplish that, NextGen has developed a PCMH reporting suite, and several of our clients have participated in this, and I'm going to kind of take you through how that works. First of all, it's a NextGen professional services, so it is offered directly from NextGen. It's a suite of patient-centered medical home 2017 National Committee for Quality Assurance, NCQA reports to support client practice transformation and maintenance as an NCQA recognized PCMH practice. The new PCMH 2017 report suite is now available, and we have deployed it or worked with NextGen to deploy it. That's an important nuance there. The reports package is sold as a flat fee and includes up to 10 hours of consulting services. That includes implementation, training, and customization within the templates themselves. We'll talk a little bit more about that. NextGen likes to say they're not necessarily selling the templates, they're selling the package, which includes the consulting services. So if you kind of look at it, it's just an all-in-one, and that's how it has to be packaged. Clients using customized KBM or customized workflows that do not fall within the standards allowed for in this package may require customization beyond what is included. If that is the case, you can purchase additional customization services. If we take a look at the suite of reports that were developed using SQL Server reporting services, it's SSRS tools, you can see the list of the reports on the side, and these are all included in the package. It is important to note that if you do not have it, you will need SSRS installed on your servers. These are accomplished by using the data from your organization's NextGen report server reports and can be generated to support the following listed to the right, which we've kind of spoke about. The reports package is designed to work with the standard NextGen ambulatory EHR KBM content using version 5.8 or higher, KBM 8.3 or higher. Anything below that will not work with this particular reporting suite. So let's talk a little bit about the highlights within this suite. A few important things to mention is the old reports you used to generate via Crystal. Now they're using SSRS reports that are generated from the report server. First, they're going from the report server. It's a much quicker process, and the reports are a lot cleaner. There are some requirements from a technical perspective to be considered, such as what I mentioned, you must have SSRS installed on your servers. Clients can purchase these through their NextGen account representative or through their reseller. While I can work out with NextGen Consulting Services and they will be the ones deploying it, we can help you with your order if you are an iTentive reseller client, and you can get that from your own reseller or your NextGen account representative. Clients who purchase the PCMH 2017 report solution will receive an accompanying reports guide and report specification document. This documentation will provide details on workflow needed to capture reportable data. So as an example of the resources available to you, many of you may have seen these, but basically NextGen provides white papers on criteria, workflow examples similar to the quality measures under the MIPS program. So if you haven't seen these specifically, you've seen ones like these because this is what is coming from the NextGen resources. So that's really it in terms of what NextGen can provide. The tools are available to you. They are fully certified and accredited, so let NextGen help you if this is an area that you have an interest in or you're already there. We can talk about next steps. So how can we help you? By assessing your current readiness, providing recommendations, or assisting with the implementation of new processes and procedures. You can visit us at iTentive.com. You can sign up for our informative webinars and blogs, which by the fact that you're here, you've already done that, but certainly make others aware of it. You can also consider our 3-day fixed price on-site consultations, clinical workflow, revenue cycle, and front office, technology and performance, or you could test drive our products. So now we'll turn it over to questions. Okay, I'm guessing. Again, quick look for questions.
Sorry about
I think
that.
yes,
My
Cindy.
audio stopped working. I do have a couple of questions here. And again, I'm sure Cindy said so. Questions may be entered in the questions panel. We only have a couple, so I'm sure that we'll be able to get to yours if you have them. First question, is the recognition for practices or clinicians?
I can go ahead and grab that one, Chelsea. So recognition is earned at the practice level, not at an individual clinician level. A clinician within a practice that earns the PCMH recognition will be listed in the NCQA online directory of clinicians. So if a patient went to look you up, your provider would be listed underneath that practice. However, if a clinician leaves that practice, they can't take that recognition status with them. It's for how a practice operates, so it's only going to be at that practice level.
Great, thank you, Lindsay. Next question. Will NCQA visit us in person as part of the recognition process?
I can go ahead and grab that one too. NCQA doesn't actually incorporate an on-site visit. It does incorporate those virtual reviews we talked about. So it's going to be an online virtual review with an NCQA evaluator, and they're giving you feedback in real time, but no, they're not actually flying out or driving out to come on site to your practice. It's all done actually online.
Perfect, thank you. And it looks like this may be our last question. How will recognition impact my reimbursement rates?
I can grab that one as well. It's a little bit tricky to answer. It's kind of broad. Really, the only thing I have to say is that there's no one-size-fits-all answer for this. I would encourage you to talk to your payers with which you contract prior to, during, and after achieving your recognition. Let them know how you're transforming your practice. Many payers actually have initiatives that help support PCMH transformation or help you achieve higher reimbursement. So either way, you could see how they can help you. In addition, you're going to see some benefit here with the federal programs. I always go back to this. But for example, I mean, just becoming an NCQA recognized PCMH or PSP will increase your payments through the MIPS program under MACRA. So if we're looking at federal payers here. But I would just keep in mind that you can also go to the NCQA website, and they have an updated list of payer initiatives on its website as well if you're looking just for one resource to go to. But if you have any further questions on that or specific payer questions, feel free to go ahead and email me. Use my contact information that's on the screen.
Okay, perfect. Well, thank you very much, Lindsay and Cindy and Mary, and thank you for everybody for joining us today, and have a great rest of the week.
Thank you for such exciting material. It's always such a good time to present this. But in the end, it is a really, really valuable topic, and we're all excited to be part of it. It's just hard to sound that way with all of the data.
Thank you, everyone.
Thank you, everybody.
Thank you.